the female uptake was more than 50%. So that is observed in both the camp settings, but it is quite better than the rural camp. So even though the female participation is encouraging in both the is encouraging in both the settings, like most of the women were presenting at the later advanced visual impairment loss. So that is the one point that I would like to highlight here. Here we have compared the cataract surgical rate and preoperative visual acuity. The cataract surgical rate varies from 2,800 to 9,100. So even though the availability of cataract services is very strong in many of these states, like a significant proportion of the patients were presented at the blindness stage and severe visual impairment stage. So we need to adopt more like innovative approaches in order to tap the patients at early stage of cataract. And the challenge is ideally like comparing the pre-op visual acuity with the CSR, this has to be compared. The preoperative visual acuity has to be compared with the district level CSR. Since the data was not available, we have compared it with the state CSR. If you would have compared it with the district level CSR, then it would have given much more deeper insights for this sample. And then this study was conducted during the 4th year of the project. Initially, there was no intention of converting the project into a research study. So it clearly reflects a gap in our mindset to recognize and utilize all these evidences for research purpose. And then in many of the hospital, especially, we work with like not even manual medical record system is available. So getting the quality of data and using it for analysis is also a challenge. So to conclude, we found that there is no major disparity in preoperative visual acuity between rural and urban patients when analyzing on the whole. The current CAM-based approach misses early stage cataract detection. So even though we all talk about the new threshold of advising 612 or better, identifying advising these patients in the remains a significant challenge. This is because of two reasons. Like one is in many hospitals, in many hospitals, the CAM protocol is itself insists to identify the patients at operate the patients at the later stage. And the second challenge is the HR, the posted for identification of patients is one of the other challenge. There is a substantial scope to identify and treat at early stage, but we need more innovative approaches, especially that suits local demography. Early intervention not only results in better visual outcomes, but also significantly improves the overall quality of life for patients. While female participation is notably high in both rural and urban outreach programs, there is a pressing need for focused early detection initiatives to ensure women receive timely care. Thank you.
Thank you, Ms. It's good that you highlight the need for robust data capturing mechanisms. So, any questions from the audience? Yes, please.
So for what, sir? A pre-op visual acuity is actually the uncorrected PA distance. Yeah. I think so. Snellen chart. These are all outreach and done by other.
So we didn't collect which charts they use. So that's not part of the data set. Like Suganya said, the study idea came much later. So this is more data from operational data that's collected. So that we're assuming it would be a Snellen's chart, which is the common thing that we use.
Thank you. Good presentation, good attempt. My query is when you write visual acuity, is the person visual acuity in better eye or you're taking that specific eye which is operated or something? So eye-wise visual acuity or is a person-wise visual acuity
It is
to define
eye-wise,
blindness?
eye-wise visual
So
acuity.
it is blindness is based on in that specific eye person
Yes,
is
sir.
blind.
Yes, sir.
And second thing, I believe when you're associated with your like state or even with district CSR, the single hospital data may be like there may not be association with district level CSR because there may be many partner hospitals and that may affect the outcome or even the number of surgeries in that district. So
Yes.
probably that association
It's
is not
not
required.
appropriate. Okay.
Hi. I was interested in your spectacle provision rate, and congratulations for actually doing the long-term follow-up and thinking about that, because a lot of programs just do the cataract surgery and they forget about it. So in terms of the spectacle provision, you had 41% in the rural and then I think about 19% in the urban, which to me, I think it seems quite low. So I assume that the correction that you're talking about is only for distance vision. So the correction of the residual uncorrected refractive error. But what about near vision?
So this included both near and distance vision only. But we have analyzed why the rates were low. Maybe if the data is available with the partners, maybe we can go further step to analyze the reason for the low uptake, especially in the urban camps.
Okay,
It's
so
because
this
it's
is
only
about
19%.
Yeah, sorry. So this is about the uptake and not the actual number of people who needed the glasses afterwards.
Sorry, it is actual number of patients who needed glasses. I think like most of the patients received the spectacles for spectacle correction, since the outcome was better in the urban side. I think only 20% of the patients required spectacles post-operatively.
So my question is, because I assume that you're not using multifocal IOLs, not correcting for both distance and near. So most cases you'll be measuring for distance visual acuity and the residual glasses, residual refractive error.
Yes.
And so you give the glasses for distance, but then quite a significant proportion of patients would actually require reading glasses after cataract surgery because the lens doesn't accommodate.
Correct.
So did you do that, or is
No,
just not
we have
captured?
not. This is just a retrospective study, so we have not.
Okay. So I think near glasses after cataract surgery is something to consider.
So I can help, but the data you see is a combination of some of these hospitals may have had great systems for providing the glasses, some may not. So that also is kind of is in there, and even in most places you may not give everybody correction for near vision, because if you find that person is not literate, he really doesn't have any need for near vision glasses, then you just don't dispense it. So it's a combination of both.
Thank you, Suganya.